Now that we've gone through 3 years of this, in the Hispanic Latino population across the state, which has different nuances, what do you think the priorities should be from the pediatric children's perspective, and what are you seeing in the field that are indicators from all of your experience and what you do on a regular basis?
Well, so I think the main thing that we need to do is keep trying, keep getting the word out there. Because if we don't, then it's just gonna, if you talk to a lot of parents right now, it's like at the beginning of COVID, they had this false narrative in their mind. Just because I have a children that's very healthy, they're not gonna get the any variant that's coming our way. Well, if you look at the data, statistics, and everything that has happened, healthy children are the ones hitting that peg, correct? So that's one thing that we need to keep working on, keeping informing our community. This is happening. It's not going to go away anytime soon. What are we going to do about it? I think with children, we need to be 10 steps ahead of the new variant that is already coming. So what do you think, Dr. Rodriguez? You interact with children a lot more than I do, so what's your take on it?
Absolutely, you're exactly correct. We have to be proactive, especially now that the decision will soon come to start vaccinating 6 months and older. That narrative, that understanding, that perception that parents have, well, my kids are healthy. I don't hear too many histories about death in children. We already explained data drives decisions, and the decisions have all been targeted at the adult population. It's time now to pay more attention to children. And when I encounter the exact same things you do. When I encounter families, I have to remind them, this is still very prevalent. Children are getting admitted to ICUs. It's very transmissible. We have to have the conversation about the basics, especially vaccination.
And one thing I noticed by working with both of you from two different perspectives is I think teams have been very successful, especially in our population, Hispanic Latino, because there's also the cultural nuances, the linguistic. We're not monolithic. We do not all come from the same country of origin. But what I reflect upon, what I think is one of the greatest successes, and I'd like to have you tell me from your purview, is it takes a village. And how I message as a stakeholder has to be in concert with how you message as a clinician and how you message in field operations. And we're also multi-generational in ourselves. So I think that of all the things that were accomplished, during this, is the importance of partnership, but the diversity and the stakeholdership of those partnerships to connect the dots. From a clinician's perspective, if you can only see who's in your office, and your patients, but if you uplift a Dr. Rodriguez by being in the field, or I do by being a trusted stakeholder or messenger, then that spreads the word more intrinsically. What are your thought processes on that, and how do you think that has helped and how it could be improved?
Absolutely, yes. You're right. I see a one-on-one, the moment of truth happening in that room when I'm with that mom, dad, child, teenager. So I try to create rapport, trust, a sense of safety. I share my own personal experiences, not to be vulnerable in their eyes, but to show them I'm human too, and I have family, I have grandchildren. I talk to teenagers a little differently than I will talk to small children. But I'm hoping that the message reaches, and that when they are seeking that message, they come to the right person, their provider, nonprofits, hospital associations, organizations, reputable, without bias, without hidden agendas, science, is the driving force that help us make decisions to stay healthy, and that folks in the field, advocates, providers, we all have the same message, same message, same message. You cannot drop the guard. You have to be constant. In every corner, there's a stop sign for a reason, right? I tell my medical students and residents that I teach, what is important is redundant. All through our career, we're bombarded, we're scrutinized. All through our training, same things have to be done the same way, correctly, all the time. And we have to have that message, and the sources of the messages have to be easily identifiable.
And trusted. Santiago, what's your perspective on that? You have such depth in that question.
Right on point on what you're saying. I think it takes a village, as you were saying. So it's like, what are you bringing to the table? What am I bringing to the table? What are they bringing to the table? Correct. So at this point, if we combine it together, that's how we create a trusted message to give out. Because the resources, they're there for everyone, wealthy or not, no matter race, we're not talking about, this is for everyone. As you can see, COVID impacted absolutely everyone in this world. So I think this is the time where we come together and we figure out, this is what I'm going to give you. What are you bringing to me? And then this is how we can offer it to the community, correct? So once we put that message out there, it's a matter of them getting it and wanting to listen to what we have to say and what we're trying to, at the end of the day, we're just trying to protect them, correct? Because at least from my perspective, I am fully vaccinated. I believe, so it's like we're fully vaccinated, correct? They're not. And that's what we're trying to create here, get them to be protected for their own good, correct?
Absolutely. I think some of the other things is if we could look at, you spoke about speaking to teens. And speaking to teens is not always an easy subject about anything. Could you explain from your vantage point how you communicate differently versus when you're speaking to a parent or guardian to their younger child? What messaging do you use that's different? How do you approach that? Because I think it could help people like Santiago and myself learning from someone who is medically trained to know what is effective in the big picture.
By statute of law, all states have the same statute. When it comes to reproductive and mental health needs, starting at the age of 11 in Georgia, the patient has the right to talk to me in private. And I talk to them both with the parents present and with them in private. Sometimes there's a little bit of tension. Sometimes things are not said or expressed the same. There are fears, misunderstandings. So the patient is learning, how do I take care of myself? And we give them the opportunity to start talking the conversation in private. And what do we talk? We do validated screening tools. We do them for substance use, mental health, depression, anxiety, food insecurity, school performance. We have some things we are obligated to go through. But then when I'm one-on-one with a teenager, I want to know what state of mind are they? What are the deficits and strengths in their environment? It's important to identify the deficits like violence in the house, substance use in the house, food insecurity in the house, all those social determinants and adverse childhood events, how it's impacting them. But the solution of a deficit-based model of approaching care is the strength. What are the strengths? In times of crisis, do they have a network? How resiliency? So I explore resiliency, how school. Just this morning, in the news in Puerto Rico, I just learned that 20% of the children either fail to pass grade or they're at risk. And it's just because two years of having in virtual education play a big role. For the first time, we have a generation that skip a lot of learning in 2 years. So is it loneliness, how it's affecting their eating? Some kids don't have eating disorders. However, they have anxiety, eating in front of others without a mask. So how do they perceive the environment? How are they internalizing the values and the way they make their own decisions, look into the future? So I talk to them about, are we going to repeat the grade? How about summer? Could there be summer classes? How about work? Things that make them happy. You have a relationship with a boy or a girl. Do you have to? Would you like to go back in person or live? Virtual to do schooling. So we ask about general things with the intention to create rapport. Rapport is a French word that means coming together.
And that's hugely significant. And Santiago, I think your input to that is very helpful too. I know that we have implemented best in practices. We have been in the field since the onset of COVID. We do deal with a lot of children from what we do for the population. And to what Dr. Rodriguez just poignantly said, I think there's some other subjects there. If you look at comorbidities, if you look at food insecurity, performance in school, HPV, other vaccinations. Could you speak a little bit of education from the field perspective, which definitively complements what clinicians like Dr. Rodriguez perform in best in practices within their hospital systems and practices?
Yeah, so I think once you're in the field, you kind of see this dynamic going on with the parents and the teenagers. When it's time to get the vaccine, they come in and they might come with the younger sibling, correct? That's like maybe eight or 9. So the little kid, he knows that he's going to get the vaccine because that's the parent's decision, correct? He knows that he's getting out of there. Even if he's crying, he's going to get it. With the teenagers, it's more like they make their own decisions at this point. So it's like, how do we talk to them? How do we let them know that this is for your own good instead of just forcing them to get it, So when we're out in the field, we try to create activities for them. So we have an nutritionist on site, and we have board games. Recently, we just started doing, interactions with them. So it's like creating that trust, that kind of like one-on-one kind of conversation. And then if you go deeper into the conversation, you're thinking like, well, the flu season is about to come. And so the flurona that they're now calling, because they have those symptoms, and it's like, so which one? Do I have the flu or do I have the rona? Like, which one, So it's like, summer is starting. They want to go to Six Flags. They want to go to the water park. They want to go to the beach. They want to do all these activities with their friends, correct? Get vaccinated so that you don't have to worry as much about, ooh, do I have COVID? Am I going to bring it home to my parents, to my siblings, to my grandparents if they live in the same house? So I think it's a matter of creating that kind of communication. And I think what you do with them, that's perfect. Talking to them with the parents, but when you have that one-on-one conversation, they're obviously going to open more to you just because the parents are not there, correct? So I think it's just a matter of creating new activities. It's like sometimes improvising and figuring out, how am I going to get you to understand why this is good for you, if that makes sense.
Absolutely, and I think that was the mission behind why a lot of us in support of clinicians like yourself designed best in practices for education and communication to our population as a whole that brings on the elements of boosters and COVID-19 and so forth with pediatrics and young adults. You touched upon, both of you, some elements to the other issues that occurred. I think it would be very important for the audience to understand some of the other elements our Hispanic Latino population suffered as a result of the pandemic. Domestic violence, alcohol situations, education, behavioral science issues, living in very close confines for a very long amount of time, the insecurity of the not known. Most people don't like what they don't know because they don't know what the future is going to bring. let's kind of break that down and have a conversation about that. Dr. Rodriguez, do you want to touch base on it?
Yes, I see the work that you do as completing what I do, complementing what I do. Something that I can do that might not be available for you is that I have the privilege to have continuity of care. So I see the numerous times, even if it's just once a year. In the theory, there's a theory of change. People are go through pre-contemplation, contemplation, planning, action, maintenance, and sometimes whether it's eating disorder, depression, the things that you address, sometimes they won't tell you the first time, or the second time, or the 10th time. But luckily, they do have someone. They can go to you for certain opportunities and needs, and you have to be there to provide them. And then hopefully, I will have the opportunity. It's called change talk versus sustained talk. So we're training, identifying these, maintaining that continuity, developing that trust, that safe space, rapport, and addressing specifically the Latino, something that we learned, confirmed, and came out tremendously through this pandemic is the equity, disparity, poverty. It came out all different, not just in the Latino, but in many other communities too. Losing a loved one, source of income, changing roles in their household, food, we talk about food insecurity, mental health, so many things that were much more prevalent. We could see them much easier coming out because of the inequities, disparities in equity.
And I very much appreciate that. And I always add to that, it seems that it tenfolds when you go into where our Hispanic Latino population lives in rural Georgia, or most rural states, but in our own state, because there's less access to, one, those who understand our population, and two, there's less access, like many underserved populations, because they're in rural areas and transportation and food becomes an issue. Santiago, I know you deal with it just like Dr. Rodriguez and I do. Kind of give me your perspective, and I'd like for us to also speak to, and what can we look to do better now that we spent 3 years learning the lessons? How do we further putting in practices, best in practices, to have better health outcomes in totality?
Yeah, well, I think the first thing that we need to do is understand the community and where they're coming from. We have to fight hesitancy, but how do we do that if we don't understand where this hesitancy is coming from, correct? So we need to make sure that they feel confident enough to come to us and tell us, hey, I'm going through, and this is not just for the COVID vaccine, we're talking all chronic diseases. I want to get the COVID vaccine, but I have this couple questions about it. Or do I need insurance? Like I don't have insurance. Can I get the vaccine if I don't have insurance? Or how much does it cost? Can I afford the vaccine? And this is for not just COVID again. This is for like all chronic diseases. So I think understanding where they're coming from is the first thing we need to do, and then we need to go ahead and fight it. The way we're doing it out there, spreading the word, creating this type of materials, letting them know. You don't need insurance if you go to these places. You don't need this if you go to these places. You have a specific question, well, we have a specific answer. Here, go here, look it up. It's like we're here for you. So I think that's the very first step that we need to do. And then moving forward, we kind of ship into they want the help. How do we help them? So like the incentives, for instance, that we do and we provide for everyone. And this is something, most people are like, well, if the COVID vaccine is good for me, then why are you paying me to get it? Well, think about this whole entire world is looking for the vaccine, and we all want to get it, correct, because it's safe for you. And then on top of that, we have to create incentives for you to get it. So this is how hard the hesitancy that we've been having to fight is, that we have to pay you and for you to get it. And it's actually funny that it happens that way. But they even question it that way. Well, if the vaccine is good for me, then why are you paying me to get it? Well, it's gotten to that point because you don't want to listen to us, and now we have to incentivize you somehow. So if we can provide the communities and get straight to the ones that need us the most, the underserved communities, the minorities, I think that's where we need to be, and I think that's where we're gonna go and have like the biggest impact, if that makes sense.
Yeah, normalizing asking questions, seeking help, normalizing that, removing the stigma. Am I undocumented? Am I poor? Do I have mental health issues? Removing the stigma. And the incentive part, in Georgia, only, in the United States, only 35% of children less than 5 to 11 receive their first dose. 29% have received 2 dosages. And from 12 to 17, 68%, and only 59% the second dose. So imagine, what do we need? What percentage do we need to break this epidemic? Just to compare numbers, when we talk about measles, we know measles is extremely contagious, and it requires 95% of any given community to be vaccinated to keep measles under control, 95%. And here we are, 35% in small children, 68 in first dose, and the second dose, and now we know we need a booster. So it's the incentive, fairs, bringing famous people, whatever it takes to get the attention of people. I'm all in favor to have creative ways to increase the immunization.
And not assuming that everyone knows. I think that's where stakeholder and partnerships come together. And you touched upon a very valid point. It's also history. So if we look at measles, we look at chicken pox, we look at meningitis, we look at elements that have been around for decades, and we've had polio, we've had vaccinations and immunizations. I think it's also the education of how you message, and I think history teaches us a lot from that. Dr. Rodriguez, can you, from a doctor's perspective, try to explain the impact and why people should think of history?
Thank you so much. And now we talked earlier about data, context and meaning turns into information, useful information become knowledge, and then time passes and you develop wisdom. So here I'm going to answer that with a little bit of wisdom.
So now we know why all that data was so important.
Yes, because the ultimate is develop wisdom. I'm 69 years old. 40 years doing this. I have a little bit of history to tell. Thank you. Excellent observation. I lived a time of meningitis from pneumococcal infections and Haemophilus influenza bacteria, causing ear infections, infected joints and meningitis and death and deafness and amputation of limbs. Really nasty things, which was what prompted this country to react so quickly and efficiently in vaccinating children against meningitis. And we don't see it anymore. I haven't done a spinal tap in over 20 years. These vaccines are amazing. It's like fluoride for your teeth. Maybe one day you won't have to go to the dentist. I don't know. It's a joke, of course.
We won't let the dentist know.
No. I haven't had a cavity filled for a long time. So history teaches us. We address. We have 100 children less than a year dying from COVID, over 1,000 less than 18. Well, when you look back at history and you do the numbers, pneumococcal vaccine, children will get ear infection, they get meningitis. There were about 30,000 hospitalizations a year. We already talked about hospitalizations. We had about 300 healthy children die from meningitis due to pneumococcal a year. And we jump immediately. We just want more and more vaccines covering. Now we give it to adults. I had to have boosters too for those germs can give you pneumonia, meningitis, chickenpox. I remember the time when the vaccine was available. I myself was hesitant. Said, well, this is a rite of passage. I mean, 30 years ago, we had about 4 million babies born every year and about 4 million cases of chickenpox every year. Some people will have parties to get their preschoolers to expose to chickenpox, so when they go to school, they don't get chickenpox, literally. So, but how can we vaccinate? How come it's so important? We don't allow them. Well, the chickenpox vaccine was created to help children when they survive cancer, leukemia, to help them not to die from chickenpox. And it works so well in the leukemia population. We adopted all over the world and the reason is that we discover every year out of those 4 million children getting chickenpox, about 100 healthy children die a year from chickenpox. Healthy children. So imagine, that was enough to make us jump and vaccinate everybody, made it mandatory for school. COVID is no different. In fact, COVID is even worse. So now that the vaccine is going to be available soon at 6 months, it's imperative that pediatricians, first of all, be the ones to recognize, oh, I've gone through this before in my life, and then get everybody on board